Hi, good evening, good afternoon, good morning, wherever you are. Welcome to the Journal Club of the International Academy for Clinical Hematology. It is 7 p.m. in Paris, 7 p.m. in Salamanca, 7 p.m. in Nantes, 6 p.m. in London, noon in New York, and it is my great pleasure to welcome you to this new Journal Club of the IACH. Before starting, I'd like to acknowledge the support we receive through an unrestricted educational grant. So the article for today that was selected by the steering committee of the IACH is this one published by Garces and colleagues in the Journal of Clinical Oncology, entitled Circulating Tumor Cells for the Staging of Patient with Newly Diagnosed Transplant-Eligible Multiple Myeloma. And here I would like to give a disclaimer, because in the same issue of the JCO, there were also another two articles dealing with the same topic, one by Dr. Bertamini and colleagues, and that was focused mainly on the 40 trial, and another article by Dr. Hofsteop Brunik and colleagues, including the Cassiope trial, but also EMN 12 trial. And obviously, we had to make a choice on one of these three articles, and we chose the Garces trial because we had already a couple of journal clubs involving the 40 trial and some colleagues who run this trial, but also the Cassiope trial. And we're very fortunate having today to discuss this article, the senior author of this paper, Dr. Bruno Paiva. Thank you, Bruno, for joining us. And the other panelist is a master in the field of multiple myeloma, namely Professor Jean-Luc Harousseau. So you can see the abstract of this article, and I think it's a relatively straightforward story, because if I would like to summarize this into a couple of words, I think it's about developing a liquid biopsy in multiple myeloma. So the question is whether we can find, whether we can identify, whether we can quantify circulating tumor cells in patients with multiple myeloma. And if this is feasible, what would be the value, the usefulness, or the prognostic impact of such a result? And indeed, the authors, the team of Dr. Paiva, were able to rely on the GEM 2012 MON OS65 trial, but also on the GEM 2014 trial to assess this issue of circulating tumor cells. And these are trials, by the way, which were focused on the young and the transplant-eligible patient. And the median follow-up was quite decent, 5 years. And the methods being used is multicolor flow cytometry or next generation flow cytometry. There was a sensitivity around 2 times 10 minus 6. And actually, they could find that up to 92% of newly diagnosed multiple myeloma patients have circulating tumor cells. And there was some correlation, we may wish to discuss this, with the bone marrow plasma cell burden, and they were able to detect a cutoff. And you can see here the correlation between the percentage of circulating tumor cells in the peripheral blood versus bone marrow plasma cells by morphology, but also by flow cytometry. And as you may guess, just from a practical point of view, this would be a huge advance for the patient, because obviously, if you can avoid the bone marrow aspirate, the bone marrow biopsy, which are not the nicest, I would say, investigation we can propose to a patient, then definitely this is going to be a breakthrough approach if it is validated and widely adopted, especially that, well, it may have, but we need to discuss this, some prognostic impact on, for instance, the outcome of these patients. And I'm just showing here, actually, the overall survival panel. Of course, the full article has different other panels, but I thought the shape of this blue flat curve at 100% is very elegant and would deserve, I think, some discussion. And last but not least, I think beside the editorial that was published in the same issue of the JCO by Dr. Chakraborty and Dr. Lynch, very nice editorial, the editors who handled this article by Dr. Garces and colleagues clearly actually acknowledge that these results may represent, the CTC numbers may represent a surrogate marker of both disease burden, but also dissemination. And maybe in the near future, we may be able to include circulating tumor cells into the list of routine lab tests in the peripheral blood. And this is why we thought that it would be very interesting, very exciting to discuss all of this with Dr. Paiva, who led this amazing work, and have a panelist such Professor Harousseau, who have really very deep and huge knowledge in this field since the last 30 or 40 years or so. So thank you both for joining us. Congratulations, Bruno, for this lovely publication in JCO. And the JCO impact factor, by the way, has rocketed because the impact factors were released today. And it's incredible now what you can achieve in terms of impact factor when it comes to JCO. And this is, we're very grateful to the American Society of Clinical Oncology teams and to the editors working on this. So usually the tradition in the journal club is to ask the first question to the non-co-author, so to the other panelists. So the first question would be to you, Jean-Luc. And it's very simple. Once you have seen this paper, what was your first impression? Because I think the story about the tumor burden in multiple myeloma is relatively an old story. I remember I was a very young child, I think, or student in the 80s, all the work about beta-2 microglobulin, Regis Bataille and his team. Then later in the 90s, the plasma cell labeling index and trying to characterize the cells in the bone marrow. And now, of course, in the meantime, we had all the developments about MRD evaluation. And now suddenly Bruno and other colleagues in the other articles are bringing this relatively straightforward issue of circulating tumor cells. So what was your impression? What's your take on this paper?
Well, first, I'd like to thank you, Mohammed, for inviting me and for reminding that my experience is related to my age. Well, when I read this paper, I thought it was very important, very interesting and very important. Overall, it's focused on the prognostic impact of circulating tumor cells in newly diagnosed multiple myeloma, and specifically in transplant-eligible patients. It's a good paper because there is a relatively large number of patients, more than 300, enough follow-up, and that, of course, and because, of course, it It has been written by a very skilled and experienced team on the field of flow cytometry. So what are the messages for me? The first message is that there is a correlation with bone marrow plasma cell infiltration, but only modest, which could mean that circulating tumor cells are important not only because they are related to the tumor burden, but also because they can be related to active disease dissemination. The second message is that these proportion of circulating tumor cells at diagnosis is correlated to other prognostic factors like the ISS, the R2 ISS, and of course the cytogenetic abnormalities, but it is an independent prognostic factor. And there is a correlation between the proportion of circulating tumor cells and the outcome, progression-free survival, and at a lesser degree, overall survival. What is very important that it could be in the future included into the prognostic analysis at diagnosis, and the authors tried to develop a new stratification system, adding the R2 ISS and the circulating tumor cells. We can maybe discuss the ways they did that, but it might be a new stratification system. So why is it so important, in my opinion? Well, it's because prognostic classification is becoming more and more important in the current period where we have so many new therapeutics and new procedures. And in the past, prognostic stratification was mostly an individual objective to try to assess the prognosis of a given patient. But now it's more a collective interest. It's useful for checking that all studies, all groups in different studies are comparable with the same proportion of patients with high-risk disease. And a good stratification enables us to compare results of different strategy or compare results of new treatments. And finally, with the large number of new possibility and the fantastic improvement of therapeutics, it is becoming more and more interesting to try and tailor the treatment to the initial severity of the disease. So that is really a very important objective for the current treatment. And I have to say that we don't have a good system to predict the prognosis and to classify the different subgroup of patients. They commonly use R2 ISS, RISS, Revised International Staging System, is certainly not enough reliable, and there are many concerns regarding these RISS. So I think that adding circulating tumor cells to the current system might improve the prognostication. Of course, there are some limits to this paper, and the first one is the number of patients. For instance, patients with undetectable circulating tumor cell who have such a fantastic prognosis, there are only 30. So we need to have more patients. And the second problem is that it only focuses on transplant-eligible patients, like the other two papers. And we know that a prognostic classification must address all types of myeloma, not only the young patient, but also the elderly patient, transplant non-eligible, and maybe the relapsed patient. Nevertheless, I think that, of course, the results are preliminary. They have to be confirmed by larger study, but they are very important for the future. And I totally agree with the conclusion of the author saying that it is time to revise the current system and to include circulating tumor cells in the prognostic classification.
Well, thank you very much, Jean-Luc. It looks like to me that you are rather very positive about this paper.
I have some concern. I have some concern.
Okay, but we will discuss the weaknesses.
Practical concern.
We will discuss the weaknesses. That's the principle of the Journal Club. Actually, we will discuss the pro and cons, the pluses and minuses. And by the way, I would like to remind our audience that, of course, you can send your questions and your comments, and I'll do my best to share them with the panelists. So now my question for you, Bruno, before going into some of the limitations, but also strengths highlighted by Jean-Luc, is just to explain to our audience the rationale behind doing this work. Because I must confess, I was personally a little bit surprised when I saw this paper, because I thought the name of Bruno Paiva and his group is usually linked to MRD assessment. And suddenly, I saw circulating tumor cells. So I thought that was very intriguing. So what is the rationale and behind this story before we go into the details?
Okay. Well, first, thank you, Mohammed, for the very kind invitation. It is an honor to our group, to participate in the Journal Club of the International Academy for Clinical Hematology. And I also like to thank you for acknowledging at the very beginning of today's Journal Club that these were indeed three manuscripts being published in the same issue of the JCO. I think that illustrates the power of collaboration. I think that the manuscript from the Dutch group is already a collaboration per se, since it involved different investigators from different countries and a pooled analysis of more than one clinical trial. And I must acknowledge also that the manuscripts published by the Spanish and the Italian group were an outstanding collaboration. These were in fact companion manuscripts submitted simultaneously to the journal. And again, it emphasizes the value of collaboration between our colleagues, and also the value of reproducibility. I'm not sure if these manuscripts were to be accepted in this very prestigious journal if it wasn't by their companion, and to some large extent, the reproducibility in the results across the different studies. And I would also like to acknowledge, obviously, the editors of the journal and the reviewers. Now it is safe to say that we have gone through, I think, 5 or 6 rounds of revision, 5 reviewers, and these were outstanding reviewers. And I can only say that the current version of the manuscripts is different from the original one, and it is remarkably improved by the input of the different reviewers. And I think this is a very good appraisal of what is collaboration and peer review. Now, the foundation of the manuscript. I think that both you and Jean-Luc addressed very well the importance of risk stratification. It has been important for decades. It will be much more important in the near future, hopefully, with the advent of newer therapies to frontline treatment in myeloma. Particularly if we think that we are reaching an era where it will not be adding more to triplets or quadruplets, but rather choosing from different 3 or 4 drug regimens. And choosing will be about maximizing outcomes according to patients' risk and prognosis, and the expectation of a certain PFS with this schema or a different schema. Then if you think on improving recertification, I think that clearly there is a straightforward pathway in terms of genetics by adding more abnormalities, and the French group has been pivotal in this regard. And there is another very important paper in 2019 from Aurore Perrot from the French group, suggesting a score, a simple score for improving recertification. And we felt that another way of improving complementarity independently would be by adding a tumor burden biomarker. It should be, I should be reminded that tumor burden is a key parameter for differential diagnosis, but not that much for prognostication, considering that, for example, beta-2M is an indirect measurement of tumor burden, not a direct one. And because of previous data by our group in terms of the biology of those cells circulating in blood, that, as Jean-Luc correctly pointed out, is not that much a matter of tumor burden, but a snapshot in real time of what is the rate of disease dissemination. We felt that chances were that tumor burden in blood were more prognostic than in the marrow. And it is not our aim to replace bone marrow aspirates. This will continue to be gold standard, but to offer something new and eventually more powerful in peripheral blood. And therefore, when this trial and others of the Spanish group were initiated, we felt that it was a time to make a prospective assessment using the best tool. And here we come back to the MRD, the best tool we have for detecting very small clones, either in the marrow or in this case in peripheral blood, was to use next generation flow as developed by the Euroflow consortium. So it was very easy for our group just to implement the same technology, but in blood at the time of diagnosis.
Excellent. Thank you very much, Bruno, for explaining the rationale and the context. And by the way, you alluded to the companion paper, and I would like papers, and I'd like to say hello to Dr. Luca Bertamini, who is actually the first author of one of the other papers and who is following this journal club. So hello, Luca. So Jean-Luc, the question here I have for you is that, and actually you mentioned the revised ISS. Actually, the story started initially with beta-2 microglobulin, LDH. Then we built the ISS. Then we built the revised ISS. More recently, we had the revised, I would say, ISS. Where do you see this circulating tumor cell index or whatever measurement fitting there? Is it something that would replace at some point the whatever revised ISS, or is this something that we need to add into the ISS or revised ISS to further refine the stratification, the prognostication of the patient?
Well, I think I'm not really able to answer this question, and it will be a hard job to try and reach a consensus regarding the best risk stratification system. What I have to say is that the revised ISS is not currently a good system for a number of reasons. The first is very practical, is that it's a three-stage system, and the intermediate level is too big. It's roughly 2/3 of the patient. But there are other very important criticisms to the revised ISS. The first one is that the three genetic abnormalities are not well defined. The deletion 17p is not defined at all, and we know that the number of cells harvesting the abnormality is very important. The prognostic of translocation 414 is not uniform there are very poor prognosis, poor outcome, but there are also patients who have not such a poor outcome with translocation 4/14. And the value of translocation 14/16 has always been a concern, and it's a rare abnormality, only 2 to 3%, and usually associated with other abnormalities. But they are on the opposite. There are other abnormalities which are now known as very important, like gain or amplification of chromosome 1q or deletion of chromosome 1p. So in my opinion, it's necessary to revise at least the cytogenetic classification. And as Bruno said, this is what the IFM done, and the paper by Harousseau described a new system based on a multi-parameter definition of cytogenetic risk. The problem is that it's only cytogenetic, and maybe it's important to have all other biologic markers. That's the reason why there is another attempt, which is R2 ISS, which was recently published on a large number of patients, more than 10,000. And it is designed by the addition of the new, recently known cytogenetic abnormalities to the RISS. And it turned out that there are now 4 different levels: low risk, intermediate low, intermediate high, and high risk, which is not that easy. So they are obliged to merge 1 and 2 and 3 and 4. But it's another attempt to improve the prognostic, the risk stratification. As I said initially, I do think that including CTC would be another approach, because it's not only the tumor burden, but also the disease dissemination, and it's very important. And in my opinion, the best risk stratification system should include cytogenetic abnormalities, well-defined, validated, and the CTC plus another biologic marker. But what is written and underlined in this paper is that it is urgent to work on this new system. And I think that it's the role of the International Myeloma Working Group to try and improve the currently accepted risk stratification system.
Excellent. Thank you very much, Jean-Luc. So here we have a couple of questions for you, Bruno. And this is, for instance, why flow cytometry? So I'm not reproducing the question exactly as it is, and this has been suggested by Dr. Vedat Aslan, is about, for instance, circulating tumor DNA versus flow cytometry. That's one point. The other question we have from Dr. Maria del Rosario Custodiano is about whether these circulating tumor cells can be useful in some specific situations like extramedullary disease, plasmacytomas, or they can be helpful when, you know, the bone marrow infiltration is minimalistic. And we do have some of these borderline patients, and usually they are excluded from clinical trials, which is a pity because they have authentic multiple myeloma, but then they didn't reach, you know, the magic number of plasma cells, you know, in the bone marrows.
May I add a question, a related question to Bruno? What could be the role of circulating tumor cell in high risk, in the definition of high risk smoldering myeloma?
So Bruno, you have a lot on your plate.
Okay, let me start with Jean-Luc, and then Mohammed, I'll ask you to please refresh my memory about the other 2 questions.
No problem.
Yes, and I was sharing this with Mohammed before we started. We are engaging in all stages of the disease with the possibility of measuring tumor burden and then treatment efficacy based on peripheral blood. To address part of one of the other questions, yes, we usually do it by flow. It's our technique of choice. We are biased. This is no secret to anyone, but also because it has several advantages. Cost effectiveness is one of them. Broad availability is another. And we need to think on broad availability towards creating consensus risk models, and the fact that you don't need the bone marrow, for example, to define the VVJ rearrangement that you need to follow, for example, using sequencing techniques in peripheral blood. Also, while quantifying DNA or studying circulating tumor DNA, the quantification, in my opinion, is not that trivial. And in fact, circulating tumor DNA has been used more commonly to assess genetic alterations. And in this regard, those genetic alterations are usually mutations and not that much the structural abnormalities that are key prognostic factors in myeloma. And this is related to technical challenges of studying short fragments of DNA. Back to your question, yes, we believe that as in active myeloma, there is also a clear role in smoldering myeloma to offer the possibility of replacing not the diagnosis, but during follow-up bone marrow plasma cells, and therefore having your 2220 model being reassessed, for example, every 3 or 6 months or every year, according to patient risk. It's just that it will not be 20 as a cutoff, it will be another cutoff for CTCs, but really defining stable versus evolving patterns. And this is complementary to the M component and the 3 light chains. We are studying it in MGUS. We believe that studying CTCs in MGUS will be critical to discriminate between gammopathies of no significance versus those of some significance due to risk of transformation. And we are trying to increase the sensitivity of NGF to make it more powerful to measure treatment efficacy, particularly during the maintenance and observation stages. It will be more difficult during induction or treatment intensification. But certainly having the possibility of measuring it in blood during observation every 6 months, for example, will be important to identify early MRD reappearance, for example, if this would be a trigger, for example, to start an early intervention.
So let me ask here a question to Jean-Luc. Jean-Luc, do you see a role of the CTCs in the follow-up of the patient and in detecting early relapse? Because obviously we speak a lot about MRD, but there is still some controversy about how to use MRD to guide the treatment and to make decisions. Would the appearance of circulating tumor cells, and I'll come back to Bruno about the cutoff, because the cutoff in your study, Bruno, is 0.01%, whereas in Bertamini study, it's 0.07%. So what do you think, Jean-Luc?
Well, of course, we all agree that MRD negativity is a major prognostic factor in multiple myeloma, and maybe the most important, and should be used for tailoring or deciding the treatment. The problem is that we have to repeat bone marrow evaluation. So of course, if we could have MRD assessment in the blood by measuring circulating tumor cells, it would be much better for the patient and much easier to have sequential MRD assessment. The problem, and now I suddenly need Bruno's advice. The problem, to my knowledge, currently is the sensitivity of tumor detection in the blood after treatment is not high enough. And I remember a paper from, again, a Spanish group showing that the interest of CTC MRD assessment in the blood was only if positive. If negative, the sensitivity was not enough. If positive, you can avoid bone marrow evaluation. If negative, you don't know. So maybe, as Bruno said, by improving the sensitivity of next generation flow, this would be a possibility in the future. But to my knowledge, currently, the sensitivity is not enough.
So Bruno, so that brings me to the question about the threshold, the cutoff, which is different between your study and the Italian study based on the 40 trial. And I guess both of you did it at baseline. So in theory, there should be, we should end up with a consensus. Could it be, what are the explanations behind, these different cutoffs?
Okay, so I'll address your question about the cutoff, and if we have time later on, I think that addressing also those topics around MRD could be of interest to everyone that is watching. Now, I see it the other way around. I think that despite all the differences in terms of methodology, which was flow, but not exactly the same flow cytometry method, differences in treatment, even some nuances in patient characteristics, to see only a small difference of 0.06% in between the two cutoffs, I think it's quite remarkable. So I see it on the positive rather than the negative side. I think that both groups, Luca, Juanjo, and well, the whole teams, the two teams, found that what both manuscripts were saying was that any detection level above 0.01 would confer poor prognosis. And in one study, it was a little bit higher. In ours, it was 0.01. But certainly, once you start detecting above 0.01, it is affecting poorly in patient progression-free survival. Now, you want to predict to the best of your ability what will happen to a certain patient. And myself, we in the laboratory, we want to provide you the best tools. However, at the same time, we need practicality. So I do foresee a future in which, according to the availability and resources in each center, you could predict the prognosis of a patient based on the revised ISS, if that is all you have, or the R2 ISS, if you have information on 1Q alterations, or a new staging system, if you also have availability of flow to measure CTCs in peripheral blood. And the more resources, the best your ability to predict outcomes. And because we need to make it simple and practical on routine grounds, we need cutoffs. But the truth is that the continuous numerical value might be the best prognostic indicator. I'm sure you will understand this if I allude to the example of AML. In AML, we have 10 plus different genetic subtypes, all of them related to a certain prognosis and even treatment indication. Yet for simplicity, we need to group all of those into 3 risk groups. And the same is happening in other diseases such as myeloma. However, and this will be more work for the future, I'm particularly attracted by very small subgroups. Those with undetectable CTCs like MGUS-like profile, but in peripheral blood, those with very high values in blood, a sort of hidden plasma cell leukemia, because I believe that it will be in the small subgroups where you have more chances of individualizing treatment, be it discontinuation because of exceptional outcomes or exploring a different alternative because of dismal outcomes with current standard of care.
So Jean-Luc, thank you, Bruno. Jean-Luc, I think everybody is acknowledging the technique is relatively simple, non-invasive, feasible. So my question to you, because you've been running myeloma clinical trials for many years, and they have really been impactful and changed the natural history of the disease, would you be willing today, because when it comes to high-risk multiple myeloma, we usually almost exclusively rely on the high-risk cytogenetics at baseline, and we identify this subgroup. Would you be willing to include this circulating tumor cell value, irrespective of the threshold and cutoff? We can agree on something to design clinical trials which are enriched for a high-risk patient. And this would further, I think, personalize our approach to the treatment. Is this a relevant, valid venue to use these circulating tumor cells?
The problem, Mohammed, is, as I said, the role of a risk stratification system is to compare strategies. So it has to be accepted by all. If it's not accepted, suppose the IFM uses CDC in addition to cytogenetic system. And we publish that, and we show that there is a high-risk group which can be treated with a quadruplet plus bispecific antibodies and another with better prognosis. But the system is not accepted, is not validated. So to answer your question, I think that we are not yet ready to introduce CTC in the algorithm of decided treatment. We need more data, and we certainly need a consensus. And I think, again, it's the role of the IMWG to make this consensus. But I would like to emphasize what Bruno said. A risk stratification system must be simple, reliable, and simple. If it's too complicated, if it's not widely applicable, it will not be used. Remember the gene expression profiling. That was a fantastic prognostic factor. The Arkansas developed a very useful gene expression profiling system. And there was another in France, another in Holland, another in UK. And this was not applicable because it was too complicated, too expensive. So we have to suddenly look at a relatively simple staging system. And CDC, as Bruno said, by next generation flow is not that difficult. And cytogenetic analysis needs one bone marrow aspiration, but it is feasible. So I think that we have to work on that. And if there is a consensus, then the IFM could introduce CTC in a new trial. Remember that in the absence of a good risk stratification system, we decided to tailor our treatment not on the initial prognosis, but on the response to treatment.
The dynamic assessment based on MRD. So actually, you are really fantastic two panelists because you're making my life very easy. That brings me to the last question for you, Bruno, which is about what are the next steps? What are the perspectives? Great paper, I think, confirmed in 2 other independent studies. So I think the truth is there. So now what are the next steps, the perspective of this work?
Well, just a small comment. Indeed, there is significant effort in tailoring treatment based on depth of response, but because, as you mentioned, both of you mentioned, risk is dynamic, I do believe that great granularity of diagnosis combined with the depth of response after treatment will be mandatory to really define patient subgroups in which you can individualize to the best of your ability treatment. So we need efforts on both sides. So for the future, definitely more studies, as you mentioned at the beginning, more studies including transplant-ineligible patients, also at relapse. And it is fair to say that we must follow the efforts that you and others in the field have done, for example, for cytogenetics, and this has required decades of efforts and data sets of 10,000 patients to really produce reliable, robust data so that the International Myeloma Working Group can define a new model where CTCs may become part. So I fully agree with Jean-Luc's comment that this was an important first step that must be consolidated by more data, by our, and very importantly, other groups to show reproducibility, to produce more data in the shortest amount of time, and thereby to find a consensus model where CTCs will be a value, for example, to identify patients that may lack a high risk cytogenetic abnormality, but may have, like I said before, a hidden plasma cell leukemia, and therefore this will help you identify with a different biomarker a functional high-risk patient.
Fantastic.
Excellent conclusion.
Fantastic. Thank you very much, Bruno. And by the way, we have a lot of positive comments from patients and the patient advocacy groups congratulating you on this, because obviously if we can do a lot of things just by a blood sample, that makes the life of our patient much easier, but also our life at the hospital very easier. Okay, so I'd like to thank you both. I'd like to conclude this journal club. I hope everybody has enjoyed it. I do apologize we couldn't take all the questions, but obviously I'm sure you can reach out to Bruno or to Jean-Luc. Again, congratulations to Bruno, congratulations to Dr. Bertamini and colleagues, congratulations to Dr. Harousseau, I hope I'm pronouncing it very nicely, and colleagues for this really amazing research, opening a new frontier, I think, for us in the multiple myeloma field. One would wonder why we didn't think about it earlier, because, you know, just looking into the circulating tumor cell in the blood, we know how to do this in hematology, you know, in many other diseases, but we never stop the progress. So thank you very much. And wherever you are, I wish you a good evening, a good night, a good afternoon, a good day. Please stay safe and keep well. Thank you.
Thank you. Okay. I can disconnect, correct?
Yes, absolutely.
Okay, Mohammed, this was fun.
Absolutely.
and stimulating.
Absolutely. Thank you so much.
Thank you. Have a good day. Bye-bye.